It's with pleasure that we have invited Jane Phillips here. Jane is the inaugural Professor of Palliative Nursing at the University of Notre Dame, Australia. She's based at the Sacred Heart Hospice attached to St Vincent's Hospital, and she co-leads the Palliative Care Clinical Trials Unit at Sacred Heart in St Vincent's Hospital, Sydney. Jane was explaining to me that she commenced on this clinical academic pathway in 2009, and since then she's been focused on improving care outcomes for people in the last years of their life by strengthening the nexus between research, policy and practice. She's currently undertaking studies to evaluate non-pharmacological interventions to improve breathlessness and health service research to improve care outcomes for older people. Today we're going to hear about the outcomes of the first Cancer Challenge of the year, which was Spaced Education, a tool to translate pain assessment and management evidence into practice. So Prince of Wales was a site here for this. Jane's going to speak, and then we're going to invite some of her co-investigators to come up at the end to facilitate discussion. Thank you, Jane.
So thank you very much for the invitation to present this morning. We're indeed very honoured, and also very honoured that you've managed to get up quite early and battle return to school traffic and get here on time. So as Vivian and Robin said, our team was awarded the first Cancer Challenge in 2012, so we started in June 2012. And what I'm going to do in this presentation is take you on a quick overview of that journey. And I'd like to acknowledge other members of the research team, because obviously whenever you're doing research it never happens with one person. And many of my colleagues, co-investigators, are here this morning, and I'll invite them up to the podium a little later. But particularly to Nicole Henniker, who was a project officer and did a fantastic job, my colleague Louise Hickman at UTS, who is really a curriculum expert, Dr. Jane Ingham, a palliative care consultant at St Vincent's Sacred Heart, Lawrence Lamb, the most patient biostatistician I've ever worked with, who started off being in Australia and has now co-located to Hong Kong, which was great the last couple of days because they're 3 hours behind. It's unfortunate that it's Chinese New Year. And my colleague Tim Shaw, who I've worked really closely with, who is in actual fact the spaced education expert. So what I'm going to do, as I said, was just provide some context with how we actually came to be awarded this, or how we think we came to be awarded this, present you some pilot data from the pilot study, give you a summation of where we've been, and preliminary data. I must stress that the data that I'm going to present this morning is very preliminary. We literally only finished data collection, I think the last Thursday, finished data entry on Friday. We've been busy cleaning it, so it's very, very preliminary results that we're presenting. And then I want to speak to you about next steps, so where we as the people that have completed the challenge think we need to be going, and we want to think about that in terms of patients, providers, being healthcare professionals, and at the systems level. Well, I don't have to remind you that every day in our clinical practice that we see patients in pain, and I find it quite distressing in 2014 that many of our patients with cancer and or in palliative care services continue to have unrelieved pain. And the estimates really vary in the literature, but it's somewhere between 30 and 75% of people with cancer will actually have pain. And yet these are people who are actually seeing health professionals, and often many health professionals on a regular basis. We know, if we look at all the international guidelines, that one of the fundamental principles of good pain management is assessment. And that assessment is a continuous process of not only, and it's got to be done very comprehensively. It starts with screening. We actually need to obtain a patient-reported outcome, be that a numerical rating score, so patients rate their pain. We then need to, if they've got pain, need to proceed to undertake a comprehensive pain assessment, and then we need to make sure that we come back and reassess them after we've put some intervention in place. And many of us, and myself included, having spent a lot of time working in specialist palliative care, would say, but we're actually experts, and in actual fact that's what we do. But I'll come to explain that perhaps we're not as good as we would like to think we are. And I guess what happens if we fail to adhere to those fundamental principles, then really we're playing a role in contributing to unnecessary suffering for our patients. They will often have poorer outcomes. Many of our patients may be endeavouring to maintain work, maintain family life, maintain their quality of life. And also too, I think we also need to remember that unrelieved pain contributes to caregiver distress. So, as I said, I work in specialist palliative care, and this is some data that probably really prompted me to embark on this journey. And this was data that was collected through, and is collected every year through the Palliative Care Clinical Outcomes Collaborative, which is a national Commonwealth government funded initiative that the majority of specialist palliative care services across Australia are involved in. So every day in palliative care in Australia, patients are asked to report their physical or symptom assessment scores, and then once or twice a year we actually send out surveys to patients and caregivers to complete. And this was the data from 2009 from one specialist service, which will remain anonymous, which really indicates that a number of these patients, when asked how much pain they had in the last 3 days, had about, were rating moderate to severe pain, and that was 82%. And when we looked at the national, compared that to the national benchmark, it was significantly higher, because the national benchmark was 62% of patients were saying that they were had pain. Bearing in mind that this is actually data from services that would call themselves specialist palliative care services. So these aren't services where patients are just being seen by general practitioners or not being seen by staff with palliative care qualifications. So in order to better understand why these patients were saying that their pain wasn't as well managed as it ought to be, we actually undertook a chart audit. We looked at the way in which pain was managed in the last 72 hours of life. And what we actually found is that only 9% of patients in this specialist palliative care unit actually had any documented evidence of having had a pain assessment undertaken. That doesn't mean a pain assessment wasn't done, but there was no documented evidence either in the progress notes or on a pain assessment tool. And in actual fact, we didn't find one pain assessment tool. So that really led us to then sort of go to the evidence and sort of say, well, what does the evidence tell us? Is this actually really what's happening in clinical practice? And these came from a guideline document, and it sort of makes a number of key points which we were really seeing in the clinical setting. And the fact is that we've got clinical guidelines, but clinicians are not necessarily adhering to them, and that staff overall, even those working in specialist areas, actually have quite poor pain assessment and reassessment practices. And they made some suggestions about what might be effective in terms of narrowing that evidence practice gap. And they had suggested, advanced practice nurses may bridge the gap. And they also talked about the need for perhaps research that was really actually looking at organisational change and change that would enable clinicians to engage more with clinical guidelines. So we felt that we actually needed to take action and endeavour to try and improve our pain outcomes through our patients. And there's many areas that you could endeavour to focus on, but it seemed to me that if we didn't have staff documenting around pain assessment, that in actual fact that would probably be a good place to start. So as I said, we had very little evidence of documented routine pain assessment, and that was actually for nurses and palliative care physicians alike. Please bear in mind, I'm not saying they weren't doing it, but if they were doing it, they definitely weren't documenting it. And I guess given the other problem is that given the nature of our workforce, the need to often have agency staff, having part-time workers, we're actually really quite dependent on the clinical records being accurate to enable a smooth transition between care teams. And I've already spoken to you about pain management being a continuous cycle. And then when we looked at the literature about what sort of interventions have been undertaken, what we did find is that we could not locate one intervention that had exclusively focused on pain assessment practices, all of the interventions had actually rolled assessment and management into the one intervention. And many of the interventions had really focused on pharmacological strategies, so drug-related strategies. And we felt that that was kind of a real gap as well, that we perhaps needed to narrow it down and just focus exclusively on pain assessment. This is a really, there are many models for conceiving what translational research looks like. And I guess this is a model I find really helpful to think about. For those of you perhaps working in wet labs, and it's very much about that T1 research, that you're trying to get that great new discovery translated to the bedside. And I guess for people like myself, I'm really more interested in the road less travelled, but where we can probably make really quite significant gains. And that's probably getting the evidence from the bookshelf to the bedside and into practice. So this project essentially was really focusing on the dissemination, or as Robin mentioned earlier, implementation research. And it seemed appropriate to think about some sort of educational intervention. So when we started to look, and because I knew of Tim's work, I was really interested to find out more about QStream. And QStream, and Tim will be able to answer additional questions at the end of it, but this is just a really quick overview. It's a really novel, interactive online learning platform that it was developed at Harvard Medical School. It's actually been assessed in over 12 randomised clinical trials, predominantly with doctors, which has demonstrated increasing knowledge and the retention of knowledge over time and some change in clinical behaviour. It's really based on the creation of very authentic case-based learning scenarios. So the scenarios really need to speak to the clinical problem that you're wanting to address. And in many respects, the clinical scenarios, to me, mirror clinical decision-making and practice. And that to ensure that they're authentic, they're really best developed by a panel of clinical experts. And it's built around two fundamental evidence-based theories, and that is the principle that learning is best when we test the effect of the new content and we space learning. So what we actually see, that information which is presented, repeated over spaced intervals, hence that's where the original name came from, but it's subsequently moved to be called and registered as QStream, is learnt and retained more effectively compared to traditional methods of education. I apologise for my croaky voice. So it's about giving short, concise, packaged learning content delivered at spaced intervals, as opposed to what most of us would experience in terms of learning, which is actually really like bolus dose education, or turning up for CPD exhausted and spending 40 minutes like you are now listening. It may not be the most effective way to learn, whereas spaced education has shown we just give you a small amount of content and we deliver it at spaced intervals that may be more effective. So what does it look like? This is an example of one of the cases that we used in the pilot study. So it looks fairly simple. It describes a scenario, a clinical scenario. As you can see, they're fairly pithy. There's not too much detail, just the bare bones of what the expert panel felt clinicians needed to have to make the decision. And then you get a multi-choice question. In our original pilot, we also enabled participants to provide an answer using a tweet format, so we called that an open 140. So as soon as, the way it works is that you enrol in spaced education. When you've enrolled, you will actually periodically, every couple of days, and the investigators or the people administering the education can set up the spacing and the number of questions that you receive. You'll get an email in your inbox. You click on the email, it takes you to the site if all of the IT is working, but that's another story which I won't go into. But there are some challenges in our health services around firewalls. But in theory, you would just go straight to the question, you read the question, you think about it, you answer it. As soon as you've actually submitted your response, you get immediate feedback. So your answer is benchmarked against everybody else in the course who has provided an answer. So you get a bit of an idea of how, if you've got it wrong, how many other people got it wrong. If you've got it right, the proportion of your colleagues who've got it right. You actually get a take-home message, which is short and sharp about, what's the impact of the clinical decision, and then it goes on to the consequences. And we really tried to tailor that to what would be the consequence of your decision on the patient outcome, and then links to evidence-based practice. That's what spaced education is, and it's a series. In the study that we did, we actually had 11 case-based scenarios that we developed. So now I want to talk to you about the results of the pilot study, which we had started and had some very preliminary data at the time that the TCRN called for the Cancer Challenge of the Year. So it was conducted across 2 specialist palliative care units in New South Wales, and we recruited more participants, but the analysis was done on 34 participants, and I'll explain why. As I said, it was an intervention that just looked at case-based learning using QStream. It was 11 case-based scenarios around pain assessment. Because of the small sample size, we were aware that we wouldn't have the power to do a randomised controlled trial, and so the best design that we could come up with was a pre-test, post-test, quasi-experimental design. This was designed to collect data at 4 points in time, so baseline data, survey data, and chart audit data. I just want to speak to you for a moment about the tools that we had to develop to collect the data. So once again, when we went to the literature to find a validated tool that would assess clinicians' pain assessment capabilities, there is a dearth of tools out there, and in actual fact, the few tools that are available to assess clinicians' pain management capabilities really focus on pain management, and a lot of them are related to drug titration calculations. So they're very much around not prescribing, but really the management as opposed to assessment. So therefore we then had to pause, which you never really want to do in a study, and actually develop a survey instrument, which I'm delighted to say we only need 20 more participants, and which we hopefully will have in the next month, and we're partway through doing a validation, and we will have completed the validation of the survey instrument we've developed, but that's another story. So developed the survey, and we wanted a survey that really just focused on pain assessment capabilities and clinicians' confidence to undertake pain assessment. We also needed to develop a case report form to undertake the chart audits and test that, which we did. And we also really, most importantly, wanted to be able to collect patient-reported pain outcomes. And because in palliative care we collect patient-reported pain ratings on a daily basis, we were actually able to do that. So these are the results of the pilot study. Even though we had conducted a study and we wanted to do it at 4 points in time, the attrition was quite significant. So we had 2 smaller numbers to really do analysis at T3 and T4. And in many respects that reflected the initial survey, which was far too long and too burdensome for participants, and that was the feedback we got. But getting back to the results, and this is pilot data, results, what we were able to demonstrate at the end of the pilot study is that the participants who completed the intervention, so they did the survey, completed the intervention and the follow-up survey, they had demonstrated they had increased their pain assessment knowledge, their pain assessment tool knowledge, and their confidence to undertake a pain assessment. And the participants, those that had actually completed the online learning module, were more likely to be the clinicians who were documenting pain intensity scores in the patient's medical records, the non-participants. And I've included the results there. And when we looked at the patient's reported pain ratings, what we actually saw between the admission and the audit date was there was a reduction in mean reported pain outcomes of 1.5, which we were really kind of pleased about this data because it conferred some confidence that the intervention had obviously, something had happened in this environment. Because it wasn't a randomised controlled trial, we can't attribute it all to the intervention, but it was, we felt really quite confident to proceed. In palliative care or cancer services, we would consider a mean reduction of 2 as being clinically significant for patients. So this is a non-pharmacological intervention. Admittedly, it's not controlled, and we've had a 1.5 mean reduction. We also sought feedback from participants, because one of the things that was really important was to really get, it's all very fine to have this fabulous online system, but if participants don't really like it, and if there are things that we could be doing to refine it. So this is just a snapshot of some of the feedback that we actually got from it. We got a number of suggestions. We got some pretty full and frank feedback as well. And the other thing, which I haven't sort of included here, but I think it's important to mention, is there was a difference between the nurses who completed the spaced education intervention than those that didn't. And if you were a nurse that had been working at the specialist palliative care units for less than 2 years, you were more likely to participate and complete the intervention than participants who had actually been at the sites for a long period of time. And some of our palliative care units really have staff who have been working in these units for quite a considerable period of time. The other thing that struck us, if you didn't have good IT competencies, if you had challenges accessing the online learning, that was a real deterrent. So it's probably an application that doesn't necessarily appeal to everybody. So with all of that information in mind, when the TCRN called for the Cancer Challenge of the Year, and from memory it was a pretty tight timeline, we actually thought, why don't we throw our hat in the ring? We think we could actually use what we've learnt in palliative care to actually take it to the cancer setting and see if we can actually make a difference. So that was our brief. That's what, for $100,000 we needed to do. And we were very fortunate to be successful. So the TCRN has a 6-step model that they like the Cancer Challenge team to adopt, and it's their translational research model, and it's really about how we would get existing evidence into practice. So the data that I'm going to present from here on in is really going in accordance with this model that has been adopted. So in thinking about the TCRN challenge, we just thought it was a great opportunity for us as clinical researchers and researchers to really partner with clinicians across the TCRN who were interested and looking at creative ways that we could actually build improved cancer pain outcomes. But we did want to use QStream, and we did want to focus on pain assessment given the work that we had done in palliative care and our assumptions that we had. But we also felt that because we had all this chart audit data, that it would be appropriate to perhaps provide back to the sites some information about their audit, their feedback around their pain assessment practices. And at the time we were writing this, a Cochrane review came out which suggested that audit and feedback had moderate impact on changing clinician behaviour in terms of getting it better, more aligned with clinical practice guidelines. So this was the research question that we set out to answer. We really want to know that does spaced education make a difference to clinicians' commitment to undertaking and documenting routine comprehensive pain assessment findings and reduce cancer and palliative care patients' reports of pain. We started with cancer and palliative care because this study was also going to be open to the palliative care teams as well. So they're the aims of the study. So we're actually looking for an improvement as a primary outcome in documentation around comprehensive pain assessment findings in the medical records, and the secondary aims are that we actually want to increase, demonstrating we can increase clinicians' pain assessment knowledge, attitudes and behaviours, and ideally we set out and we really wanted to be able to demonstrate, can we make a difference to patient-reported pain scores by 2 points. Unfortunately, we're unable to measure that, and I'll explain why. So we, excuse me, we went out and approached all of the eligible, basically any unit providing cancer care within the Translational Cancer Research Network was eligible to participate. And we wanted to make it open to doctors and nurses as well. However, in the people who've actually taken it up have only been nurses. And interestingly, it has only been conducted in the inpatient setting. So the data I'm reporting to you today involves nurses within the inpatient setting. So we had 7 inpatient departments providing cancer care that were involved across 5 TCRN sites. So the study design, once again, we really want to do a randomised controlled trial, but with consultation with the biostatistician, we felt that we wouldn't actually have the numbers required to, we wouldn't have sufficient power. So we had to go back to doing a pre-test, post-test prospective follow-up study, but we also implemented a nested case crossover design at one site, which was a waitlisted control. So participants were randomised, so they wanted to participate, they could enrolled, they undertook the baseline assessment, and then they were randomised to either get the spaced education immediately and complete, or they went on to a waitlisted control arm. And once we had finished collecting the assessment at time 3, the participants on the waitlisted control arm were able to complete the study. So the data collection tools was the survey tool that we had refined because we'd undertaken some preliminary factor analysis. It had good internal reliability, and we've used that in the subsequent study. So the items that we're most interested in, and we call this a self-perceived pain assessment competency survey, it's a 17-item survey. 7 of the items focus on pain assessment knowledge, 3 on pain assessment tool knowledge, and 7 items on confidence. We used reworked the chart audit tool to better capture the data that we were going to be able to get across each of the sites. And probably for me as a clinician, one of the most disappointing things is that we weren't able to collect patient-reported pain scores, because in cancer, unlike palliative care, you don't collect that routinely for your patients. So, and there were just too many gaps when we actually looked at the way that information is captured. It's very inconsistent. So in cancer care, and I don't think the TCRN cancer services are any different to cancer services across Australia, we do have big gaps in capturing patient-reported outcomes on a routine basis when we see our patients, be that when they come in as inpatients or in ambulatory care. So I just want to talk for a moment about the addition of the audit and feedback, because I've spoken to you about the pilot component for spatial education. But these were the principles that the Cochrane review suggested ought to be integrated into any feedback, audit and feedback. And we have endeavoured to sort of comply with those as best we could. There were some challenges around doing that because we had some the ethics had some concerns about us providing feedback, audit and feedback back to clinicians, the way in which that information would be handled. And so we went from wanting to do an individual audit and feedback, which is probably has been demonstrated to probably be the most effective way of providing feedback, to actually just providing site feedback that was benchmarked. It was face-to-face feedback in a one-off session. We provided written information, we've provided a brief report, and it's in a format that clinicians, the nurses on the ward, can actually use for QI activities, and we do hope that they will take that on and report it and build upon the gaps that we had identified, but also to the strengths that had occurred. The audit and feedback were focused on the difference between what we found at baseline and what we found at T2. We endeavoured to engage the highest level of nurses as well as the ward nurses. and the decision was made that it would be an experienced RN from the research team that would actually provide the audit. So we were able to tick all of those boxes that we had. We were able to adhere to what was recommended in the Cochrane review. So this is the project plan, and I'll just walk you through it. So it's data's collected at 4 points. So it's a long, it's quite a long study. So it went from week 1 to week 41. So at time 1, we're collecting all the baseline data. It's where the randomisation happened for the weight control group. Intervention happened between weeks 5 and 21, where people were able to complete the online module. On average, it took most participants about 28 days. Some completed it much shorter, some took much longer. Then as soon as the participants had finished the online module, we actually administered the survey to participants. And then when everybody had finished at each site, the online module, we actually went in and collected the chart audit data for a predefined period that was only known to the research team. And we repeated the survey data at time 3, which was week 31. And it was after we collected the survey data at time 3 that we then went back site by site and provided the feedback, the audit and feedback to each one of the participating sites. And then once that was completed at weeks 38, we actually went back and collected the data. And that's the data we have just finished collecting last Thursday. So it is very, very wet data in terms of the chart audit data. And so the data, the feedback I'll give you is very preliminary. So in order to get that project happening, as I mentioned at the outset, it doesn't just happen with 1 or 2 people doing it. To take on a project that's really of this magnitude, that's really about engagement and really about winning the hearts and minds of people, requires a whole team of people. So we were indeed fortunate to have a great project advisory group with representatives from each one of the participating sites. We also identified clinical champions who we worked really closely with, and they were a key part of the project in terms of making sure that information about the project, where we were up to, and encouraging people to keep participating and providing advice to us was a key item. The other thing that was really quite important, which the TCRN engaged in, was that we undertook an assessment of site resource requirements, because what became apparent is that many nurses across the network actually didn't have ready access to computers, and if we were wanting nurses to be able to do the online learning during work time, then they needed to have access, computer access. Obviously ethics and governance, and that was arduous. That's probably all I will say. It took 6 months of daily negotiation to get approval to conduct this study, which wasn't consenting or recruiting patients, up and running, and it was consumed an enormous amount of time. And obviously getting participants recruitment was a really big job, and the ongoing reporting requirements. So as I've alluded to, the data is work in progress, but it's will be coming soon. But I can present some quite preliminary data. And the first data I want to present is around the survey results. So as I mentioned, it's quite preliminary. But we had a potential sample of 208 nurses. So 208 nurses worked across the participating sites, who met the eligibility criteria. We ended up with 125 consenting to be involved in the study, 95 completed the T1 survey, 52 went on to complete the intervention, 48 completed the T2 survey, and at T3 we had 44. So we've had, which is not dissimilar to what we had in the pilot project, but we've had greater adherence at T2 and T3. So the analysis that's reported is on the sample that completed all of it, so it's a sample of 44 participants. This is just to give you a breakdown of the 44 participants who have completed the survey. So the mean age, it's a younger cohort than we saw in palliative care, so about 33 years. Not surprisingly, it's predominantly women. The majority are registered nurses, and more than half actually are bachelor degree prepared nurses. The years of experience, so the participants really reflect almost a third of fairly new to cancer, or new to nursing, and more experience, and similarly the degree of cancer care experience. So we've got a combination in this sample of nurses with fairly new to cancer, new to nursing, and to nurses that have worked more extensively in cancer care. And the majority were providing direct clinical care, and they were undertaking a pain assessment greater than once a day. So this is the preliminary analysis for the pain assessment knowledge. So what we've been able to demonstrate is that there has been a significant increase in pain assessment knowledge from T1 to T2, and that there is no change from T2 to T3. So what that means is that the nurses increase their pain assessment knowledge following the intervention, and that knowledge was retained out to 10 weeks. So that's a positive result, and is in keeping with other studies. This is the pain assessment tool knowledge. We see a similar pattern, so we see a mean increase from T1 to T2, and then at teeth increasing at T3. So that's actually I apologise because the headings aren't correct. T1, they will need to be moved across to the right. My apologies for that, but that is also significant. We see a different pattern with the pain assessment confidence. What we actually see, once again, this is what happens when you cut and paste at 4 o'clock in the morning. So the T1, are you following me? T1 should, the column that it says T2 is actually T1, and they all need to move to the right one. So, but the pattern we see with the pain assessment confidence data is that the nurses at baseline feel very confident about their pain assessment practices, but after the intervention, their confidence has actually fallen. But when we go back at T3, it's actually increased. So what we're seeing is, really, I'm actually quite confident doing pain assessment. I do the spaced education. I perhaps reflect and get some new knowledge and reflect on my practice. And then I get the survey and think, actually, perhaps I'm not as confident as I thought I was, even though my knowledge has gone up. But then at T3, hopefully after you've practiced, then you're actually now feeling more confident. So that is kind of interesting. So that's the survey results, that's where we're up to at the moment. So this is the chart audit data, and the data I'm just really presenting. What the process, which I haven't explained to you, was that basically we audited every chart, we screened every chart during the audit period of every patient that was admitted with a diagnosis of cancer, and we then actually audited, they remained in the audit if they had pain on admission, developed pain during admission, and that's the profile. We've only just really got that in. They're quite similar numbers, a little less at T4, and we haven't started that analysis. This is a participant feedback from the TCRN data, so once again, get quite good feedback about Q-stream being an appropriate method. So where are we up to? Next steps. Well, I think one of the things when you do something like this, we really need to think about a sustainability strategy and the implementation. And I guess I've really wanted to think this at the 3 levels, from the patient, the provider, and the systems level. And I think the way in which we can maintain better pain screening practices, if we actually had adoption of, if cancer services across Australia, not just in the TCRN, actually adopted and adhered to the Australian Cancer Pain Guidelines, which were released launched at COSA last year, because they do provide, and they're on a wiki platform, so there's no reason that they ought not to be available. And if we make a commitment to actually use what the evidence suggests, and to adopt the use of a brief pain inventory, which is what's actually recommended for pain assessment, I think we will make a difference to our patient outcomes. I think in terms of the package that we've developed, we've got an opportunity, there's opportunities to think about, should this package be used as part of the orientation for cancer nurses and medical officers and those in palliative care? And I guess probably the part I feel most disappointed about as a nurse and someone who's worked quite extensively in the community is that for whatever reason we were unable to engage, or ambulatory care cancer care nurses didn't have the capacity to actually participate in this study. Because if we think about where most of our cancer patients are actually seen, it's actually in ambulatory care, and really it's only sentinel events or quite at diagnosis that the minority who will actually end up in the inpatient situation. And I think there's much that we can actually do in ambulatory care. Should the spaced education be offered as part of a requirement on units and be done on a second yearly basis? I think also too we've got an opportunity to think about the audit and feedback, and hopefully the teams will actually use that to drive further QI initiatives. And we do have the opportunity to roll out the modules across multiple organisations. I guess one of the big challenges is actually exploring the licensing costs, the commercial ones. So I'll probably just sum up by saying I think QStream does offer the opportunity to deliver specialised clinical content in an online forum that can change practice. I think we've got the potential to integrate it into other translational research and or educational interventions. We definitely need further evaluation. Both of these studies, the numbers are still not large enough, and obviously our aim would to be do a larger controlled trial. But I would actually say to each and every one of you, as you venture back into clinical practice this morning, that we've all got opportunities to improve outcomes, the way in which we practice in our everyday, to make it better for the patients that we see and improve their pain outcomes. All of you would be familiar with this, and this project's really been about implementing exactly what we know, but actually getting it into practice. I'd just really like to acknowledge a whole range of people who've made this possible, and particularly my co-investigators, so thank you. So let me introduce my other colleagues. Nicole Henniker, the project officer, who's really done all the hard yards, and many of you will be familiar, have met Nicole. Tim Shaw, my colleague from Sydney Uni, who has done a huge amount of work around spaced education, and my colleague Louise Higneman from UTS School of Nursing. So happy to take questions. They're happy to take questions.
Nikki?
So you mentioned your attrition rate. I just wondered whether you had some of that sort of data about the demographics or education experience on the dropout. Yeah.
We do, we just haven't had time to look at it.
So you'll look at
I've pretty much just shown you all the data that we've managed to process, but that's one of the things that we're really interested to look at. Not sure that it'll be, but we'll watch this space. Coming soon.
Just to add on to the attrition thing, something I've been doing some studies in Boston at the moment, and we're looking at kind of attrition in these programs, and I've done a program across partners with nurses where we actually introduce competition, and the QStream platform actually has the ability to put in leaderboards and things like that. We've also just done a study out at Concord around that, and to try and find ways to stop the attrition rate, and we've actually found that has a significant impact. We did it in Boston. The reward was just a cake for the ward that won, but it massively increased the participation rate. Anybody who thought they'd all won trips to Fiji, but it was just a cake. So we're looking at different ways to, it's this whole thing between mandating and making education enjoyable. And in America, they're really struggling with this at the moment, so they're mandating an awful lot of incredibly boring materials. I think we need to try and make education more engaging.
Although one thing that we did have was we had about a 90% completion rate for the module itself. So the participants that started the module, 90% would actually complete. So that was great statistics.
Yeah.
I probably shouldn't also add, which I didn't really want to bore you with the details, but at one site we had major IT issues, and that was and it's quite a large site, and that was actually even having IT on site and having schmoozed IT, or we thought we had. There was still, it's actually about firewalls, and even though you're working in a network, working with hospitals, it's like dealing with fiefdoms within departments. So you would think IT across the network would be the same. No, not. Anyway, I'm sure you live with that every day.
Just on a logistical note, so just getting my head around when nurses would do this, would they like see a patient if they had a break, they quickly do a couple of case studies, or would they have a reminder through the day, or how did you?
I think there's probably 2 points I want to make about that, and then I'll let Nicole respond. One of the things we learnt from Sacred Heart was that we actually put special time aside so nurses could complete it. And the feedback we got was, I wished I could have done this at home. So in this project we actually said, you can do it from wherever. You can do it from your home computer, you can do it from your work computer. What you need to realise is that people only got 1 or 2 cases at a time, and they take less than 7 minutes to complete. 7 minutes is probably an exaggeration. Did you want to add something?
Yeah, so I think we found for this project a lot of the participants took up the option to complete it from home, because even though it is sort of fairly short space of time, you know, finding a computer if you were having IT access issues in sort of those 10 or 15 minutes that you had the downtime wasn't always easy. And we also got feedback that participants were actually really wanting to follow up on the resources and stuff, so they did want to take the time, do some extra reading. So yeah, for this project the majority I think did it outside of work.
So can you actually take the IT side out of the firewall, or is that...
Use your iPhone. I mean, that's what most people do these days. The other thing I found when I was running a similar program in America, which the ward unit managers were really happy with, that particularly in the impact in the chemotherapy wards, that the nurses would get a case and they'd talk about it together. So that actually the manager would walk in and hear the nurses discussing the case together, and they were worried were they cheating, which was great because they were actually discussing cases, actually an education on the front, so which is very encouraging.
Jane, thanks for a great presentation. I'm just interested in the ethics issue. You've raised the point that ethics was a hassle, but this is a minimal harm study. What's
We'd
the
like to
problem?
come to morning tea. I've almost forgotten about it really, to be honest, but when you come to write it up, you realise, I'm not joking, we spent 6 months. There were multiple things, and it was actually, the ethics actually wasn't a problem. And for those of you that are doing research, in this day and age, it's often not the ethics that's the issue, it's actually around the governance. And because we were external to these various hospitals, because initially what we actually wanted to do, because we actually wanted nurses, the clinical champions, we want to pay them to do the audits at each one of the hospitals, because it seems like that would be more powerful if you're auditing and you kind of get to feed it back. We would support them and do that. That was probably one ethical issue that the ethics had problems with, and they didn't want that to happen. And they also didn't want, if we were doing audit and feedback, it done on an individual basis. They were very concerned if we found suboptimal behaviour, then what was the implications for that person from a HR perspective, and how would we be able to protect them? And it just got too hard, so we just kind of went, Barley's, we'll just do it as a group, we'll just benchmark. But it was actually the governance. We actually had to have a clinical trial agreement for this low touch study. So it was very, very, it really wasted a lot of time and a lot of paper. And I'm trying not to remember it. Hi, David.
Just a couple of things. I think what you said now about governance is really powerful, and I hope you will ask the TCRN to take that back to the hospitals, because it's really not restricted to your experience. Your experience is a very sharp end of the chain. I didn't quite hear about the other objective, the secondary objective. In fact, parenthetically, the talks we give for an hour are the opposite of what you proved Q-Stream should do. We should probably do 10 minutes and go out for a walk and come back and hear the next bit. But
Totally. I would love to have done that.
the pain outcomes.
Wasn't in my brief.
The pain outcomes, because you showed in the pilot quite impressive data.
Yes.
Really hard edge. What
Yep.
you did actually changed what happened to
Yeah.
patients in the larger.
Couldn't do it because you don't.
Because of the audit problem.
No, because you don't. When I say you, I mean we in cancer care don't routinely ask our patients about their pain scores, and it's not documented.
What about use of breakthroughs?
We were looking at, but
But
it,
to know they had.
we didn't
various
actually.
ways, I guess, so we weren't asking.
Yeah, we were actually really wanting to look at documented pain scores. But I do take your point that we could have looked at medication. Kind of didn't want to get into the whole medication regime, just wanted to focus on assessment, but you do raise an interesting point. And we came into the cancer care setting thinking that we would be able to find that data in patients' notes, it would be somewhere. But in preparation for the study, once we were allowed on the sites and started looking, it was like coon cheese with big holes in it. You know, patients might have a pain rating on admission, but that wasn't generally recorded. However, you know, the data's too early to I can't give you the data, but it will be interesting to see if we've got a difference in documentation after the intervention. And I guess one of the slides I missed, but it does to me raise issues about whether we actually need to, as a sector, think about having standards for cancer care, and obviously patient-reported outcomes would be one of them. The other thing is, I must say, I was really excited when I saw the big bunker, the big hole in the ground, because you sort of think when you're building new institutions, it's a great way to think about a new way of doing things. And I have done quite a bit of work in a quite large regional cancer centre that has mosaic, and so all of the patient records, everything is in mosaic. And I think once we move to those type of systems where we've got electronic clinical records, it's much easier to capture all that pain assessment data, and everyone's actually got access to it in real time.
Thanks, Jen. I think your presentation was fantastic. One of the biggest challenges that we have is in educating nurses. And through so many different bodies, that's what we constantly try and do. And most frequently, it's actually nurses working at ward level that we find the most difficult to reach. So to have a nurse champion that could introduce this Q streaming within all oncology units would, I think, be a most amazing benefit for everybody.
Thank you. Good thought.
Well, thank you very much, and thank you for those of you who stayed over time for the question time. I'm sure that there are more people who actually want to engage with Jane and her team after this session closes. So you're welcome to come to stay and have a chat. I think that's where a lot of the most important discussion happens after Cancer Ground Rounds. So can everybody say thank you to Jane and her team for